moving to our panelists. Thank you for coming and thank you for being here. هنبدأ مع دكتور أمنية. كنت عايزة أسأل حضرتك يعني how do you weigh the cost of the preventative approach in comparison with the benefits للcardiovascular patients especially في هيئة التأمين الصحي.
بسم الله الرحمن الرحيم. شكرا على الدعوة الكريمة من الدكتور جيهان. احنا دايما في التأمين الصحي لما بنيجي نعمل انكلوجن لأي دواء جديد بنشوف يعني ايه البينيفيتس اللي احنا هناخدها قصاد الكوست اللي احنا هندفعه. فاحنا هنا مش بنتكلم بقى على الكوست كفلوس كماني، انا بشوف الفاليو بتاع الدواء بتاعي والحاجة الانوفيشن اللي انا هدخلها عندي. لو احنا بنتكلم هنا على الكارديوفاسكولار ديزيزز فاحنا زي ما شفنا الدكتور ياسر قال ان احنا الكارديوفاسكولار ديزيزز يعني الكوز نمبر 1 اوف ديث سواء ان ايجيبت او في الورلد وايد، وهنا في مصر واحد من كل 3 يعني نسبة عالية قوي. فكل الحاجات دي بتاخد في الاعتبارات كتير قوي وانا بعمل انكلوجن لاي دواء جديد. هنشوف طبعا كارديوفاسكولار ديزيزز زي ما الدكتور ياسر برضه قال ان السكند ايفنت بتبقى قريبه، والسكند لو مش كنترولد السكند ايفنت بتبقى مكلفه اكتر، كل مره بتبقى مكلفه اكتر. طيب مبادرات قوائم الانتظار زي ما كنا شايفينها في السلايد عملت اعداد كبير قوي في الفتره الاخيره من العمليات بتاعه الاوبن هارت، من العمليات بتاعه القسطره. قصاد كده ان انا ممكن لو انا في ادويه جديده ممكن تتحط في البروتوكولز ممكن تستعمل عندنا، ممكن اقلل الفرصه كتير قوي ان انا اعرض البيشنت بتاعي ان هو يعمل اوبن هارت او يعمل عمليات قسطره. كون ان هو يخش يعمل عمليه دي حاجه طبعا يعني مهدده برضه للحياه بتاعته، حاجه متعبه بالنسبه له. فلو انا بعمل له بريفنشن احسن من هو يخش ياخد هذا الاجراء. خصوصا دلوقتي الاسعار بتاعت مستلزمات العمليات الجراحيه بقت عاليه جدا، في برضو في الفتره دي نقص شويه في بعض المستلزمات. فعشان كده كل الحاجات دي بتتاخد في الاعتبار لما باجي ادخل دواء جديد. مش الكوست بس بتاعت المستلزمات، في كمان دايركت كوست وفي حاجات اندايركت كوست. يعني المريض نفسه ممكن بيجيب عن شغله، الاهله والفاميلي بتاعته كلهم ممكن يسيبوا شغلهم، في حاجات فلوس المواصلات، فلوس حاجات كتير جدا، الهوسبيتاليزيشن، حاجات كتير قوي ممكن تخش كلها في الدراسه بتاعتنا. احنا يعني مؤخرا بقالنا اكتر من سنه في الهيئه العامه للتامين الصحي اي دواء بندخله جديد في الليست بتاعتنا في اي كاتيجوري بنعمل له الاول بادجت امباكت كوست افكتيف طبعا اكيد الاول، وبعديها بادجت امباكت اشوف فعلا هل انا فعلا هستفيد قد ايه الفاليو اللي بيتادد عندي مقابل الكوست اللي انا بدفعه. فدي يمكن الكرايتيريا اللي احنا بنستعملها في التأمين.
شكرا ميرسي يا دكتور. So moving to Dr. Lubna, it's a pleasure having you with us in the panel. كنت عايزة أسأل حضرتك يعني from Dr. Omne's يعني opinion all the benefits and values that are really يعني into consideration, how can we incorporate these values and benefits into procurement and into guideline treatments for the patients into Jordan?
Okay. Thank you for your question and thank you for all. When we think about the procurement process, we are thinking about economic principles, and both of them they participate. Procurement do something good, share in the GDP. If we think about the guidelines, we rely more as a procurement guys on the PTC committee, pharmacy and therapeutic committees, to give us the guidelines. And in the context of procurement, we now in the preventive healthcare, we now should go from the lowest price tender and this thing and go to the mean tender, the most economic advantageous tender, because this is a new technology, new molecules, and we are talking about preventive healthcare. In the preventive healthcare, we are also talking about lowering the cost on the long term, not on the short term. So procurement brainstorming should go to things, as I said, on the mean tenders. And now we need to go through the strategic procurement process. In the strategic procurement process, we are now thinking about something we call all supply chain and procurement guys go through it, which is a Kraljic matrix. And by the way, Kraljic he's an economist, name is Peter Kraljic. He made a matrix and classify products to the 4 categories. In our context, we are thinking about bottleneck drugs and strategic drugs. And here we are thinking about framework agreements. So we need to discuss the price with the big pharma, make negotiations and increase access. One last thing as a procurement, and now we are all discussing this issue, is the patient involvement in the procurement, the citizen. How citizens can contribute in the procurement, in the healthcare procurement process, and we can maximize their impact as citizens in the preventive healthcare.
That's, I think, which is great. The voice of the patients is always impactful. So moving to the payer, Dr. Ahmed Siam, we would like to ask you, implementing now the universal health insurance system in Egypt, and the integration between the authorities and sharing the data between them, it's still a work in progress. So I would like to ask you about how can the payer stratify the risk factors for the ASCVD patients into making sure or ensuring the resource allocation towards treating them?
This question actually has 2 parts. When we're considering the decision in the first place, who are we going to make this specific technology available to, you have to define a specific population. And since we don't have real-world evidence, more or less we rely on literature. The other part is actually more or less the easier part, because usually there is some sort of authorization process behind it, so you can build it within the rules itself. The whole point is how you develop this rule and how you define this rule and how this rule is actually communicated with the providers. But as long as you have this sort of control measure, whether it's manual or through a system or whatever, and then you can test it more or less over time, and you can see how many patients are actually achieving their targets, how many people are actually benefiting versus how many people are not. And then you can use this more or less to renegotiate the terms of the agreement later on. If the drug actually provides well, then we will continue. If we find out that it's not providing well, then we will not be continuing. So you can do this through the pre-authorization, through sourcing the data of these patients and following up on these patients over time, whether through the system, or you can even do it manually. It's a lot of work actually, but you still can do. Mm-hmm. And then we appraise this evidence. Okay. And if there are any sorts of deviations, we already report this in our HT appraisal mm-hmm. report. And we work with the manufacturer and their vendor on how to correct whatever the issues that we find with the study, and then resubmit. And we take this collaborative approach with our manufacturers up to the point where we reach a consensus on whether this specific medication will be covered or not, and the terms of this coverage, because we all saw that NICE had a positive recommendation, so we know it's cost effective. No, that is not the issue, but we didn't see the fine print at the end of the page that there is actually an extensive population-based actually managed entry agreement. Exactly. So that's what we're more or less trying to do. So.
Thank you. So in conclusion, we've Dr. Yasser have given us an overview on the ASCVD disease, on what are the risk factors and how can we address them. Moving to the HIO, which addresses actually the benefits of addressing these risk factors into the procurement. And again, with Dr. Lubna and Dr. Ahmed Siam have addressed these benefits. So if there's anyone have a question from the audience. So thank you the panelists for coming, and thank you for everyone.